Good morning, everyone, and thank you to the Foundation and all the organizers for this opportunity. I'm going to discuss our novel technique of isoperistaltic bowel anastomosis and robot-assisted radical cystectomy. So our GI surgical colleagues were using similar technique for after the hemicolectomy, they were doing robotically, and what they have reported was the lower ILS rate. And as we know, in the cystectomy, the ILS rate has relatively remained constant, and we reported up to 27%. The isoperistaltic anastomosis, it appears more physiological. So this was the kind of anastomosis we do. And if you look at the isoperistaltic one, that is number C, it appears to follow more physiological flow of the contents in the bowel. In collaboration with our bowel surgeons, we adopted this technique and did a prospective study to see if the outcomes and its feasibility. So the study period was from March 2024 to December 2024. All patients who were undergoing radical cystectomy robot assisted with intracorporeal ILL conduit for bladder cancer. Post-operative course was monitored with bloods and clinical picture. The ILS was defined as the need for placement of nasogastric tube anytime during first hospital stay after the surgery. And a comparison was done with our historical controls from our institute from year 2014 to 2019. These are the number of patients. In the test, we have 35 patients, and the control, we have 118 patients with almost matched for age and the other groups. The ILS rate was around 11.4% in the test group, which is the people who had isoperistaltic versus 22.8% in the control group. Now, this value is going to reach significant. We had a statistic analysis. If we have the number in the test 200, this value will reach the significant value of P if the rates continue to be the same. The complication rates were almost similar. We had 0 30-day mortality in the test group, and there was no bowel leaks or anastomotic leak in either of the groups. They were also matched on the base of histology with T2 and T3 stages, almost similar in both the groups. Now, the technique involves step 1 is taking stay sutures over the desired distal ileum segment, as we do for the cystectomy. Then we create a mesenteric window as the mesenteric border below the stay sutures. Then we divide only the ileus segment using the shore form stapler, and we divide mesentery with the vessel sealer to minimize the use of stapler. Then we divide the mesentery. That's what we said. And step 5 is we align the proximal and distal small bowel segments in an isoperistaltic fashion in preparation for the anastomosis, taking 8 centimeter of overlap of the bowel segment. Now, the step 6 is we use ICG and Firefly to check the vascularity of the divided small bowel segments and conduit. And then we do the enterotomy from the left side over the antemesenteric border for stapler to pass, making sure to make enterotomy 2 centimeter away from the stapler end. Then we perform side-to-side anastomosis using single shore form stapler, as mentioned. And then we close the enterotomy using a Stratafix 3-0 suture, making sure to start from posterior angle. I'm going to show a quick video. Play this. Yeah, it's a quick video. Now this is, we do ICG injected at 0.2-0.5 milligram per kg body weight, and then we see the bowel have been aligned, and we check the vascularity of the ends. And then we, now this is the 8 centimeter of overlap. Now this is the enterotomy on the proximal segment, and this is on the distal segment. Now this is again, we take a 2 centimeter gap from the staple end of the distal segment, and also we leave a 2 centimeter gap at the staple end of the proximal segment, so that the ends do not get devascularized. The staple has been fired, and now we use the Stratafix 3-0 just to close the enterotomy. Now we do the ICG, just showing an ICG 3, the vascularity is still okay. Now this is how we start from the posterior angle, and now we are going to take a seromuscular bite in a continuous fashion. It's a small enterotomy to close. And it's very important to make sure the angles have been closed very well. And this is a final suture line. We inspect the angles and just to make sure they are okay. And it's a completed anastomosis. Okay, so the conclude reduced ILS rates using isoperistaltic technique of bowel anastomosis has been seen with this technique. Less number of shore form stapler required than the antiperistaltic technique, which also be cost effective. No increased complication rate, and it's easy to learn and use, but must use Firefly to ensure the good vascularity of bowel segment. Early results are promising, but will need larger comparative study to firmly establish its utility and safety in RARC. And we are already carrying on with this technique. We'll have the numbers soon. Thank you.
Yeah, question is that, so now in the standard manner we do isoperistaltic always. So only thing is that we don't cut again, there is an opening in the segment of the ileum. So we do it from the end only. So how it is different from when we do from the end or towards or making another opening beyond that?
So that is antiperistaltic because I showed the diagram where we do this kind of anastomosis with the two bowel. That is considered antiperistaltic because one the bowel moving in the opposite directions. That is called antiperistaltic anastomosis. So we do that way, usually standard.
But it's the same thing you are doing, right?
No, no, it's not the same. So we are using isoperistaltic. We are keeping the overlap of 8 centimeter like this on the bowel segment, and that's what we do. So this is more physiological.
But I agree with Dr. Yuvaraja's point that it looks like it's a way forward. Do you think it has such a big impact? Just one step.
Yes, sir. In our data, as I said, our ILS rates are not 27%. It's been documented. Ours are around 22%, which hasn't changed over the years, even with the ERAS protocol and even with all the techniques we have devised. Yes, there are certain patients but if you analyze the whole data, the ILS rate haven't much changed. Even in all the studies, they're reported to be between 15 to 25%. So I think this technique has consistently given a good result, giving the ILS rate of around 11% till now. We have done that analysis at 10 patients, which was again 12%. At 35 patients, still holding at 11%. We are looking at more data that by the time we reach 100, it will definitely be a significant difference between the two.
What other complications you encountered with you?
So we had no bowel leaks or anastomotic leak with this technique, and as I said, no major complications. It's similar to the other people group in the cystectomy. No anastomotic leak has been seen yet. Yeah, there is always a concern because you're using a hand suture for the anastomotic leak, but as I said, there are studies on the GI surgical side where they haven't found any difference in the anastomotic leak between the two techniques. They use for hemicolectomy with the ileocolic anastomosis, this technique.
Yeah, nice talk. I'm a pediatric surgeon and we do this all the time.
Yeah.
Very similar technique, but we use a white cartridge because what we have seen into the blue, you can end up with more bleeding rates as compared to white.
I agree, sir. I think most of the urologists here would be using the blue show from stapler for our bowel, and we haven't seen any increased bleeding rate or any problem with the blue stapler.
Yeah. In bowel and I think it's kind of standard practice.
Yeah, I think for us it is standard to use blue. We use white for the vessels, sometimes sealing for the mesentery. No, we have not even in the usual group. We don't see bleeding as a problem after anastomosis. No. Sorry. No bleeding. No, we haven't. And as I said, for the mesentery, we don't use cartridge now. We use our vessel sealer, which gives a very good hemostasis rather than using the stapler to divide the mesentery. No, not from the anastomosis. We haven't seen any bleeding. No.
If you consider it is as an antiperistaltic, which we are doing conventionally.
Yeah.
So with the ideal new bladder also will have a few segments of antiperistaltic.
So yeah.
Does it have any?
So we are not doing it in new bladder because it's a very complex surgery. So we first tried it in the ILL conduit patients because there I think we have some anatomical considerations of the ILL segment coming out, and then sometimes the bowel loops around it. That bulky segment which we make antiperistaltic sometimes creates a sort of functional obstruction there. So we haven't yet tried in a new bladder, but I think similarly we can use it in new bladder. Should give us a good result as well.
Okay, thank you.
What
Last
bowel
question.
preparation? Do you use bowel preparation?
Sorry, ma'am?
Do you do bowel preparation?
Can you please?
No, we don't do bowel preparation. No bowel preparation.
Good morning, ladies and gentlemen. My talk today is focusing on the use of Firefly during robotic partial cystectomy and how this can also be used for reimplantation work. So big thank you, obviously, to the Bladder Foundation. I echo what Dr. Bhandari said. I've been involved with the foundation in India for about 10 years, and it's great to have Prof. Gupta, who's my academic inspiration, here this morning too. So essentially, robotic partial cystectomy, there's a lot of talk about bladder preservation, but you want to ensure that we do these operations from the point of view of oncological safety, but also minimizing a loss of bladder volume. So getting a negative margin and ensuring that you don't excise too much bladder is the key. So this was our first paper that we published in 2015 from my unit on 8 cases. of robotic partial cystectomy with pretty good outcome compared to other series published. Now, the case that I'm about to present to you this morning is essentially a 76-year-old lady who came to us with recurrent UTIs and hematuria. And she was found to have a tumor at the dome, 2-centimeter tumor at the dome. And you can see the MRI depicts this quite nicely with invasion coming up towards the urachus. Her cytology was atypical, and she had a couple of red patches in her bladder. Biopsies confirmed an adenocarcinoma, and she had a colorectal and gynae workup in parallel, which was all clear. The protocol that we run in our unit with anybody who has red patches is essentially doing a blue light cystoscopy. So we did a blue light cystoscopy for her. This is not this patient's video, but we do a lot of research with AI and blue light cystoscopy. But histology in this particular patient confirmed an adenocarcinoma of urachal origin. So the task upon us was to do a robotic partial cystectomy. Obviously, oncological safety is a priority. We want to maintain capacity. But I do a lot of work with low pressure surgery. So IDS rates are high, but we do all our sort of work at about 6. And I work very closely with Prof. Gupta on my research on this. So essentially, the issues associated with robotic partial cystectomy are exactly identifying the anatomy or where to cut. Otherwise, you can take a large cuff and lose about 1/3 or even half the capacity of the bladder, which is quite detrimental to the patient, and also ensuring that you get a negative margin. So these are 2 priorities in a robotic partial. So we use a lot of ICG. We have a centralized partial nephrectomy service in our unit, doing about north of 200 cases a year. But again, the question is where in bladder can we implement what we have on the console? So we started thinking about this quite closely. Now, essentially, in this patient, the preparation involves doing a cystoscopy, marking out the lesion in the bladder, and I'll show you in this video how we collaborate, and essentially dissecting out the, dividing the urachus, just taking your time and doing this. This obviously had it along till I come to the crucial part. And once we finish marking out of the tumor at the dome of the bladder, this is the initial dissection. So we have two XI systems that we use in urology in my center, and we will also be performing a pelvic lymph node dissection. So a couple of key points for patients having partial, especially when you're taking the urachus, is to go probably slightly higher up within the muscle layer, going right to the top. And we excise the umbilicus, especially in patients who have a large tumor. But in our 23 patients, and I'll show you the data on, I don't tend to excise the umbilicus if I can help it, especially from the cosmetic point of view in younger patients. Now you can see that, whilst this looks like a fairly easy step, we're going right down, dividing the urachus, coming all the way through. And if I didn't have Firefly available on the console, I would probably be tempted to just open this wherever I thought it would be. So my registrar at this stage and my resident will actually put a flexible scope in to the bladder to mark out where the TURBT has been performed. And the moment we see this, we can actually see a stratification of where the TURBT was performed. So this really allows you to very categorically ensure that you do not overcut into the bladder. So this is the live view of what we're seeing from the cystoscope. And you can see, right on top, this is exactly where the incision was made. So it lets you open up the bladder in a very precise manner, cutting right along the margin of where you have divided, as against taking a much larger cuff than what's required, to say the least. So this is what we tend to do in our patients, and it works out quite nicely because you have vision both outside the bladder and inside. And you can see what I'm doing is just taking the perivascular fat down even more and opening it up from the point of view, doing a partial excising the urachus and doing level 2 pelvic lymph node dissection. So this is exactly where I need to cut to ensure that the bladder is opened up. And with the next incision, I actually will be right on the flexible scope. These are disposable scopes that we use, and just ensuring where we are. And the bladder capacity, as a matter of fact, can be minimized to a significant degree with this technique. And it works out quite nicely in patients that we've done so far. So there's the scope right there. And we're just sort of opening up, and you'll see the diaphragmized margin of where the TURBT was performed at the dome, which fits into play with the technique. So this particular technique can be used in quite a few different mechanisms or where we operate. Obviously, you want to minimize bladder loss, and this is data from our 23 patients. So we've had 2 patients who've recurred in our series who needed a radical cystectomy in a conduit, and 1 patient had metastatic disease at 49 months with bone mets to the upper spine, and it was actually an adenocarcinoma met, but we've had no port site mets. Now on the left side, this is exactly what we use even with our reimplantation and bladder diverticulectomy technique. So you can actually use ICG to look at the anatomy of the ureter before you anastomose robotically. And this patient that I'm just showing to you is actually had a single kidney that I had done with the ICG technique intraoperatively, plus the reimplantation of the ureter too. So again, pretty secure to say the least. So this particular patient was discharged on day 1. The cystogram done at 10 days looks quite good, hardly any loss of bladder capacity. And at a follow-up of 6 weeks, we had a T1 adenocarcinoma with negative margins with a pretty decent bladder capacity with a residual volume, and there's no disease at 9 months. So just to conclude, this is quite a good technique. It allows precision with robotic firefly, and you can use it for diverticulectomy. And also there's a big push in the UK now on robotic bladder brachytherapy, and this is what we're looking into for more and more bladder preservation. Thank you very much.
Thank you, Nikhil. Have you done lymphadenectomy in these cases, or you don't want to do lymphadenectomy?
Yes, Professor Gupta. We will do a level 2 pelvic lymph node in all these patients. And we've had our average pelvic lymph node count is about 24, but nobody had positive disease. And sometimes in these patients, we'll do a PET scan before we embark, because you don't want to be dealing with much more invasive disease. In those patients, we offer a cystectomy, but it's all about proper planning with an MRI and a PET scan preoperatively. So I'll do a lymph node in all these patients.
Yeah, nice technique. This is one of the technique to know where to cut.
Yes.
So what generally we do is that as urological tumors are almost most of the time it's extravesical.
Yes.
So we don't do radical TURBT. We just take a biopsy. It won't affect our resection, our excision. And the second thing what we do is that during the surgery, just before the surgery, we mark where we have to cut by the Collins knife. So we know where to cut. But only the initial cut may be little bit difficult. So generally we take ultrasound and see the tumor and then mark it and then cut it. So that's what we do it.
Yeah, sure.
So this is also a good technique.
No, actually. So we are tertiary unit. Most patients who get referred to us have had radical TURs. But yes, I think it's primary. You may be able to do that.
Why not cut from the inside out? Why not use your cystoscope with an electrocautery? You know exactly where you are, and now you can cut from the inside the bladder out, and your precision should be absolute.
Correct. So this is exactly what we do. So we do a TURBT on the inside with monopolar or bipolar current using a knife, and then we need to excise the outside. So I think your question is, why can't you just use a scope to cut around? You can, but I think oncologically you need to excise the urachus, and you might struggle to get with it. But maybe, with the advent of new robots, like a single port, it might be possible.
Take a margin versus your technique. Did you actually check histopathologically what is the difference in how much margin have you actually been avoiding or preventing by using your technique vis-a-vis just doing an anterior cystotomy, look inside, then circumferentially core it. So
correct. So I think
have to close the cystotomy.
Sure. I think it's all about precision to make sure you don't overcut, because with that technique you're going in line and you may actually excite much more bladder than what's actually required. As a matter of fact, this project came to light when we had to do a cystectomy on a patient who had a partial in radiotherapy with a small contracted bladder. And one of the things which came up was, have we gone in and opened the bladder too much and excised too much? So it's all about precision and where to cut.
Because the bladder has got so much of fat in it, and when you're cutting inside out, you won't be able to see through your robotic cameras. So we've tried that frequently. We keep on cutting and we get into an angle and get in wrong places. We've always used a cystoscope just to shine the light, and then from inside, you can put the cystoscope on your tie pro, and then you can watch both the screens, and you can cut from outside in, which is more safer, because a lot of the urological cancers have mucinous adenocarcinoma, and you need to have a proper wide excision for cancer control. It's just not about just taking the urachus out. So I would not advise inside out. I would say better to go from outside in, which is more oncologically correct. And then you can close your cystoscopy, because you overdo it, then your bladder capacity becomes less. So it's a big issue. So you'll have to try.
And thank you for the invitation and for the opportunity to present my work. I'm Dr. Simone Scuderi. I'm from Milan. So And I am presenting the first case series of robot-assisted radical cystectomy performed with the new Yuvaraja robotic system. So the Yuvaraja robotic platform is an innovative robotic platform that has been adopted in the field of urology, and several work show that has been involved in different urological procedures, but still we do not have large data on robot-assisted radical cystectomies. We relied on a total of 29 patients who received robot-assisted radical cystectomies with lymph node dissection between 2023 and 2025 at 5 referral centers affiliating to the EAU robotic urology section. Intraoperative complications were classified using the intraoperative adverse incident classification, and the postoperative complications were selected following the EAU recommendation and following the Clavin-Dindo classification. High-grade complications were defined as a Clavin-Dindo major occlusion. The aims of the study were to describe the surgical technique and to assess the perioperative outcomes and the 90 days complication rates. Those are the clinical characteristics of the patients. Most of the patients were male, and 25% of them had previous surgery, and 14% were N1, 9% received previous BCG, and 9% had previous neoadjuvant treatment. Regarding trocar placement, trocar was placed through the first trocar that was placed was the optic port that was placed 16 centimeters above the pubic bone, and then we placed under the direct vision the two trocars for the robotic arms on the right and on the left, and then we put a fourth arm trocar on the left, close to 3 centimeters from the pubic, from the iliac bone, and then we placed the two assistant ports. The first assistant port was put between the optic port and the first arm on the right, and the other was put laterally to the robotic arm, and still 2 fingers from the iliac bone. As we can see here, all of the centers adopted different configurations according to surgeons' preference or surgeons' habits. And this highlights the versatility, that there was basically no need for changing the usual surgical setup that the surgeon was used to have. Here we can see the case of female patients who received organ-sparing radical cystectomy with modified scular new bladder. Some audio. Is it possible to have the audio of this video?
And down to the endopelvic fascia. The umbilical ligament is then clipped and cut by the help of the ligature by the assistant. The vesical pedicles are further divided bilaterally. The peritoneum overlaying the bladder is incised, and the space between the bladder and the anterior vaginal wall is developed. Finally, the bladder is mobilized anteriorly. The urethra is incised, and a frozen section is sent to the pathologist to evaluate the urethral margins. An extended lymph node dissection is performed. The first step of the reconstruction is to perform the urethral enteric anastomosis. The mesentery of the distal ileum is gently grasped and brought down to the pelvis. A 3-0 barbed suture is then used to reapproximate the posterior urethral tissue to the ileum. This allows to remove the tension from the urethral anastomosis. A 2 cm incision is made on the anterior ileum, and the urethral ileal anastomosis is then performed. With the use of a stapler, the tract of bowel that will be used for the neobladder is isolated, and an enteroenteric anastomosis is performed to reestablish intestinal continuity. The intestinal segment is then detubularized. The assistant can introduce a suction in the intestinal lumen to facilitate the dissection. On the proximal tract, a 10 cm segment of the intestine is preserved to use as chimney for the neobladder. 3 stay sutures are placed to align the intestinal segment for the creation of the neobladder. The posterior plate of the neobladder is then closed using a running suture with a 3-0 barbed needle. The fourth robotic arm and the assistant grasper are used to hold the stay sutures and facilitate the anastomosis. The next step is the folding of the new bladder with a 3-0 barbed suture. The distal anterior wall of the new bladder is then closed distally using the same barbed suture. Next, the urethral wallus plate is performed and the stents are introduced in the ureters. The anastomosis between the new bladder chimney and the wallus plate is performed with a bunding suture using a 3-0 barbed double-armed needle. The final step of the reconstruction is to close the proximal part of the anterior wall of the new bladder.
Okay, and finally, those are the surgical outcomes. Basically, almost 50% of patients receive a new bladder, and 38% are ileal conduit, and the outcomes are pretty comparable to the literature. And this final slide is about the complications that were 14% intraoperative complications that were all grade 1, and all grade postoperative complications were recorded in 41% of patients, and high grade postoperative complication in 10% of patients. And the most common were urinary tract infection, ileus, and anemia. So in conclusion, the Uro-RAS robotic platform has demonstrated safety and feasibility in performing robotic-assisted radical cystectomy, and the outcomes were comparable to those achieved with other robotic systems. Thank you.
Thank you. Have you used Da Vinci system also, or you have used only Uro?
This is just describing the Hugo, but we also use the Da Vinci.
So your study says it is possible with the Uro. That's all.
Yeah, that's the main take messages.
Any comment?
Yeah.
Forceps in the forearm.
Yes.
Do you have any difficulty with bowel and the problem with poor grip on the current cadavers?
We were using the caddy on the right. We were changing the arms, so caddy on the right and the bowel grasper on the left. It's called small grasper retractor. It's more manipulated by the bowel.
Thank you. There's no more questions. Anyone like to ask any question to any of these speakers?
Yeah. It's actually for the last speaker. See, when you put in new technology and you bring in new machines, the patient is very, very important, agreed. But the surgeons are also important. So you should have also compared what happened with the same surgeons with the Da Vinci with the Hugo system. Did you look at it?
No.
The timings and
no, we didn't. We haven't done a direct comparison, but because those are just 29 cases from five centers, so it's
that's
just
good enough for cystectomy.
Yeah, exactly, and are just the first approach, and all of the surgeons that did these cases are highly experienced surgeons that have performed at least 50 to more than 100 cystectomies. So the aim was more see whether it was feasible to look the same technique, but of course it's very interesting to do a comparison of that.
And in the Spanish group, they didn't use staplers, is it?
The Spanish group, no.
In the fellowship, because they used only a 12 mm port, they didn't use a 15 mm port. It's such a slight shot.
Yeah, you're right, because they use they put from the other port the coupler.
So they had 3 assistants.
Yeah.
But the feeling is, having used all 3 systems, the neck pain and the fatigue on my neck at least is less with the open console like Hugo. Proper study will involve measuring the skeleton movements with 9 or 10 cameras in various locations, but that has not been done yet. Now, with the Da Vinci 5, where you're completely upright, that game might change. But there are no formal studies at this time.